we're going to talk about fiscal devolution and what it means for health. In India, everybody speaks about the Finance Commission, and that word is enough to evoke all kinds of things and all kinds of expectations and thinking and what it means, but may not be as obvious to our colleagues from abroad of what the Finance Commission implications are. So I'm just going to say one thing about it. It feels like a tectonic shift in India. It feels, and one whose aftershocks are not quite understood, and not quite, it feels like a different era of how we think about social sector spending and how we think about center-state relationship after a decade where there was a massive growth in centrally sponsored schemes. And where, for example, in health, the proportion of spending on health went from 15 to about 33% from the center in that decade. And now we are at a different era where we are saying, okay, the money now needs to go back to the states in an untied manner and be able to do that. So that offers, I think, and we have with us Mr. Girindre Beeharry, who was part of this Finance Commission, and hopefully he can walk us through the thinking behind that shift in orientation. And with this comes a series of opportunities and risk as well that we need to manage going forward. So we wanted to have people from both the center and the state. So CK is here from the center, who's looking at this from the people who now have to manage a different era of how health financing is done, and as well as we have people from West Bengal and Orissa who are on the other side of that equation. So I thank them for joining us as well. So I wanted to show one slide about the global experience on devolution. So on the y-axis, what you have is the proportion of spending that's done at a subnational level. And you can see here that countries vary quite a bit. And if you added China to this picture, it would look even more extreme, I think, on the right side of this axis here. So there's no, even though maybe from first principles, devolution, people, some of them go all the way or not all the way. The reality of it is like many countries, federal countries and so on, struggle with the right balance between federal and central, federal and state spending. And what is not on this slide is that the nature of the spending that those countries do is quite different. So South Africa, for example, I understand does much of the federal money goes to HIV/AIDS and child support and nutrition. In Indonesia, these are capitation grants to provinces and local governments. In Argentina, there are performance and incentive grants around Plan Nacer, which the country gives. In Brazil, it's a top-up payment to the Sistema Única da Saúde, the health system that's paid for by the state level. None of them do what India does, which is the PIP system, right? So, I mean, not only the amount of money that you devolve, but also how you use that money is something that actually has quite a breadth of possibilities across countries. And what can be learned from those options is something I want to discuss. But let me start with Dr. Girindre Beeharry, who was in the Finance Commission, so has seen the inner workings of this Finance Commission. He was also former NIPFP, so he has a public finance view. And he was also part of the HLEG, the high-level expert group on health. So he has also a very deep view on. So can you walk us through a little bit of thinking inside the Finance Commission on devolution, on why not go all the way? If health is a state subject, why not go all the way, for example? And why did you stop some of the way? So what is the kind of trade-off that you had to make in the course of that?
Thank you. Let me thank the Ministry of Health and Family Welfare and my former institute, National Institute of Public Finance and Policy, for inviting me. Let me very briefly start with the fact that I will not, during the course of my presentation, use the word center. I think everybody has been using the center. There is nothing like a center. The Constitution says India is a union of states. If India is a union of the states, I don't know why we are saying all the time center and making it centralized. Having said that, in fact, if you look at the Finance Commission report, there is no word center in the entire Finance Commission report. In fact, we have deliberately removed that because we don't want to focus on center. Now, if you look at the Constitution, the Finance Commission basically adhered to the Constitution. Public health, sanitation, hospitals and dispensaries are all in the state list, item number 6. And again, union government's role is institutions of scientific and technical education, specialized research, etc., and number one. Number two, drugs and poisons, which they do in good measure. Legal, medical, and other professions, these are in the concurrent list. In other words, this is predominantly a state subject. If you look at what the way in which the government of India has been spending, this is all in the report, but let me tell you. Between 2002 and 5, the union government spending on the state subjects was 14%. Between 2005 and 12, it increased to 20%. During the same period, on concurrent subjects, union government spending was 13%, and that increased to 17%. In other words, continuously there has been union government has been taking greater and greater interest in the state subjects. And in the process, of course, every state government said, including Mr. Baldi, who is sitting there, he said that, look, the union government is, why is union government interfering with our subjects? And then, in fact, they then saying that they seem to be having too much of a fiscal space to do that. And in fact, every one of the 29 states did say that, and therefore, the idea was that, the best thing is that if the constitution says that this is the state subject, I think it should be left to the states to do. But then at the same time, there is a question, and that's one of the reasons why the union government, the Finance Commission increased the devolution from 32% to 42%. But at the same time, we didn't say that there are subjects of national importance, which are extremely important, where you should ensure minimum standards of public services, including public health. For that, we said we'll leave the fiscal space, but then we also said that you can't be having 147 centrally sponsored schemes. There were 147 centrally sponsored schemes which were consolidated into 66. And then if you look at those 66 and A, B, C, D, E, you will get all the 147. Now, we said that there has to be only basic things like elementary education, basic health care, water supply and sanitation, and the like. And on these, you should have the centrally sponsored schemes, and it should be designed by a group consisting of union representatives, state representatives, and domain experts, because there is no domain experts at all in the scheme of things that happens. There is a chapter called the Towards Cooperative Federalism, and I don't think anybody reads it except how much money we get, how much money we lose. Nobody else looks at the things. But the point is that there is a very detailed analysis of this issue there. Now the question is, generally in theory, if you look at the theory of intergovernmental transfers, how do you really deal with the whole issue of transfers? One is, general purpose transfers are given to enable the states to provide comparable levels of public services at comparable tax rates. This is enabling. It is not ensuring anything. But then you have to offset the fiscal disabilities arising from revenue disabilities on cost disabilities. That is basically the objective of the general purpose transfers. In a country like India, where you have a per capita income difference, among the general category states, 1:5. If you say that, I will offset the fiscal disability completely, that means that, Bihar should be getting 5 times the per capita grants as compared to Haryana. Now, is it completely not possible? So you can't completely, politically it is infeasible. Suddenly if you say that, this is, equity will be put in so much that, they will get, 5 times per capita as compared to Haryana. So, but then we need to really, do what is minimally feasible there. But then that is the reason why, in respect of basic public services like healthcare, you need specific purpose transfers. The objective of that is to ensure minimum standards of services in respect of these areas. But then the question that we have is, what the Finance Commission did is, as I said, it increased the tax devolution. In the process, what it was doing is, it did 2 things. It adhered to the Constitution. When it adhered to the Constitution, it said, and then of course the terms of reference also did not favor that, which said that we will not make a distinction between plan and non-plan. And therefore, it took into account the plan transfers that were given earlier by the Planning Commission, which works out to somewhere about 5.5% of the divisible pool. So 32 plus 5.5 is 37.5. In addition, previous finance commissions have been going about giving all sorts of grants. Now, in fact, the 12th Finance Commission gives some grants to both education and healthcare. I don't want to comment on it. And they calculated the estimate, what is the required, and said that we don't have the money, but we will give 30%. 13th Finance Commission forgot about the healthcare. And when it came to the 14th Finance Commission, we said that, look, we will give the general purpose transfers so that, substantially higher, so that, you don't really, in fact, we try to, as much as possible, take, sort of offset the fiscal disabilities. But at the same time, say that, that we leave the space for basic, services. But in the process of doing that, we did not take any, in fact, if one looks at the 13th Finance Commission, they gave 100 crores for a medical college in Haryana, 50 crores for constructing a governor's house in Tripura, 200 crores for, they have been basically distributing, for temple rejuvenation in distinct heritage buildings and things like that. We said the only grants that were given was basically for, after tax devolution, the revenue gap grants that we estimate, and for the disaster management. Nothing more, no other grants were given in the commission. The saving on that account was 1.5% of this thing. That means the comparison is basically between 39 and 42. We also did not make a distinction between general and special category states, because that has become a major this thing here. Everybody wants to be special category. But what we did is we want to take into account the revenue disabilities, and therefore, and cost disability, and therefore we took into account the forest cover as one of the 7.5% weight we give to the forest cover, so that their problems are substantially solved. Now let me just very quickly go over to what has happened subsequently. As I said, there were 147 these things, 66, they were converted into 66 centrally sponsored schemes. And in the budget, the union government, what it did was, they kept, some of them, they, whatever the planning commission was doing, they discontinued. The remaining transfers, they converted into two categories: those with the same pattern of assistance as in the past, those with different pattern of assistance. Look at them, there are 50 of them. Now, then there was an appointment of a committee of the chief ministers, with Shivraj Singh Chauhan as this thing. But if you look at these 50, 7 specific schemes constitute 75% of the assistance. And these are Narega, Social Sector, Sarva Shiksha Abhiyan, Prime Minister Gram, Sadak Yojana, that means rural roads, national assistance, agriculture, irrigation, drinking water, national health, and housing. These are the ones which constitute 75% of the expenditures on them. Then, as I said, they appointed this committee. This committee comes up, and there has never been any comment on this committee's report. It's funny, it says all these items, which they are all in the core, so we need to continue them. These are, in fact, if you look at the core sector, it says education, health, nutrition, women and children, Swachh Bharat, rural connectivity, agriculture, access roads and communication, fisheries, housing, urban transformation, law and order, justice delivery. If everything is an important in its core, then if you have whatever little money you have, you are going to spread them very thinly across several schemes, and possibly some wisdom has to dawn on them that we need to really use the specific purpose transfers for achieving some outcomes rather than spreading it thinly across several schemes. I think it would be useful to have 5 important schemes, including health, which is the most important one. Then you say define the minimum standards with respect to that. Look at whatever aspect you want to equalize. You define that. Look at the cost of delivering in each of the states. Work out the matching ratio. Now you have a uniform matching ratio. The committee also has said 60-40 for general category. Now, they take, for example, health. The health expenditure requirements in Kerala is much less than health expenditure requirements in Bihar. If that is the case, you don't have an open-ended transfer scheme. You have limits, so you have to have a closed-ended system. It's important to have work out the matching ratio differently for different states. And the incentivization has to be done in a different manner. I mean, in fact, there is an interesting paper way back in 1975, Martin Feldstein, on the case of school education in the United States, where he talks about, sort of differential matching ratios. In other words, as far as the health is concerned, if you say that it's Kerala, Bihar, you pay 80% and the state government will pay 20%. And then in the case of Kerala, you can do the reverse. I mean, in other words, you see, you'll have to work it out on the basis of the expenditure required in these states. And that is a technical exercise, and at least some of us will have to do that. But unfortunately, that was not done. They said that, you see, for the so-called special category states, the share is 90-10, and for the remaining states, it is 60-40. What do we do from here? Where do we go from here? Advocacy is important, not only for the health sector, but we should also advocate saying that, you see, limit the number of schemes. For heaven's sake, don't spread your resources so thinly across so many states. Nobody talks about it. Everybody wants many more schemes. And every day new schemes are being, sort of floated. And, obviously you need to have a substantial increase in the tax ratio, in the absence of which, you can't be really going on spreading the resources thinly across several schemes. Minimize the number of sectors that you do. And then they talk about core of the core. I think there should be only 5 sectors where they should really, sort of intervene at this stage. And all these are in the state subjects. Given that the money has been given to the states, let the states do. They may make a mistake. Let them make the mistake, but then they will learn from the mistakes. I mean, if you say that I know everything, they don't know anything, Constitution says that they are responsible for that, and allow them to do what they want to. Need to work out, as I said, measurable service standards, and what is the service standard that we want to equalize across states, and what is the unit cost of providing them, and then similarly work out the matching ratios based thereon. And then perhaps, one of the things that people have not said is we need a multi-year budgeting. It's very funny, they have an allocation based on, sort of health requirement. Once that is done, the states are required to give the utilization certificate. And if they are not able to do that, whatever is the money not utilized is distributed among the states which are sort of utilizing. Now the question is, there are some states which only have specialized in giving utilization certificate. Whether they utilize it or not is not the issue. They are specialized in getting the utilization certificate, and once the utilization certificate given, the original allocation that you have made based on the requirement has no meaning whatsoever. And if you see the original allocation and the actual release, there is a world of difference. I don't know what we are trying to do, and we need to really clean it up, and we need to move into a multi-year budgeting system as far as health sector is concerned. Thank you very much.
Thank you, sir. Thanks for that passionate review of the Finance Commission discussion. So, CK, you are screwed, right? Essentially what he said in sum, what I summarized was states are being given more money because it's a state subject. The center was meant to play a role of ensuring minimum standard of services, but that was predicated upon the fact that the CSSs were fewer and therefore more richly funded each. Instead, we have a thin funding for many, many CSSs. So your budget remains limited. You have a number of international commitments and national commitments. Hopefully you want to have the Indian healthcare system not to be just the sum of 36 healthcare systems. So you have a significant role that is residual in the center. What has changed for you, or what will change for you in terms of how you think about the way in which the funding and the stewardship of the system happens today from the center?
Thanks, Girin. I won't get into details because there'll be a lot of discussion. I'll just try and provoke some thoughts for discussion. What has changed so far is nothing. Let's be honest about the way things are going on in the field. Every state secretary that you speak to saying that there is more devolution to the state, so proportionately the state should, invest more in health. One is confronted with a reply that the fiscal crunch still continues and we are unable to do so. What has in effect happened is, even though with the 60-40 ratio, resource available has increased, we are still trying to figure out whether that 40% is really coming. We had a difficulty with 25%. We are now looking at 40%. I hope it does. That will give the sector a lot of additional resource. Historically, and this is not because, I'm saying it because I've seen what was happening in the state, and now I am looking at it from the other side. Historically, states' investment in health with competing priorities does not find prime place today. I don't know what we need to say on that. There is a tremendous amount of debate going on with everyone that a state subject is a responsibility of the state. And I'm sure that should be. I wonder if we can treat health on the same standards. Perhaps health will have to fall differently as a responsibility of both. The reason being that if you look at the last 10 years and the way things have moved and the way healthcare has shifted, the investment from this union government has actually gone up. Rightly, wrongly, that's a debatable thing. Dr. Girindre Rao was right that it is, if the state has more resources, they know their problems better, so they should invest more in the problem areas. And Girindre said that a new era has begun. With the NHM experience, it's an era that has transformed more in terms of the physical availability rather than the processes, because those processes were set in much earlier in the NHM, where the entire planning for even the union government's money was actually made by the state. So I really wonder where we are heading, although we are very optimistic that the 40% will push up the scales a little. But what in effect it has happened is that, this is frankly speaking, when you discuss this with the finance people here in terms of more resources for health, the reply is the devolution has taken place. There is no more money available with the states. So we are dependent on the states. We don't have a fiscal space to increase your budget. So this is a dilemma we are caught with. May not have been intended, but somehow or other this is what it is coming to, and the state representatives will respond to that. There is another element with the states which we need to keep in mind. Resources and capacity to absorb are not the same everywhere. The state's capacity of absorption of resources is an element which we need to keep in mind all the while when we are planning. And, the other worry that I have is if we continue to think of resources in this way, will we be able to really pull out the laggard states which did not invest in health earlier, and how will we convince them to invest more in health to come up to some of the better states? Mr. Girindre Rao gave the example of Bihar and Kerala. How do we work this mechanism is a problem, and we are still grappling with solutions. Utilization of funds and release of money subsequently, which you mentioned, I just thought I'll bring clarity to that. I don't see a universal pattern of expertise in creating utilization certificates now that much of it is monitored on a daily basis on an online system of the services that are being provided, people that are being employed, and the payments that are being made. If some states still are doing it, is there ingenuity which we should recognize? But what I'm trying to say is the systems are in place. And so far, fund flow has never been a concern. So the basic concern that remains is, and that is to be seen, is will the states invest that additional money that they have got into health, or will it go to some other sector? Advocacy, of course. And along with advocacy, I would tend to think that as union government, even though it is in the state list, the responsibility doesn't get over. Thank you.
I'll stay with you, CK, for one more question, and then. So, I mean, what you control is your budget, and I think there is a question of the quantum, which we discussed, and how you use your budget to the 60-40 ratio and so on, raise more money from the states, but also like the manner in which you spend your money, and there is, as we saw from the earlier slide, countries actually have a very, very wide distribution of how that money is spent, whether it's performance-based, whether it's ensuring some core public goods are funded, whether it's an equity play. Very few of them have this kind of input-based or line item-based budgeting that the PIP does. So has that thinking evolved? I mean, I'll express my bias. I think this may be like a bring down the wall, Mr. Gorbachev. Is this the right time to rethink about how we do the funding process away from the input funding process and look at what is the role of the center in ensuring quality services at the state level in a way that is more congruent with global experience?
See, the present pattern of funding, if you take, is a combination of various things. It is a per capita, it is the high focus states, it's various things come into play. But perhaps if the resource situation remains the way it is, I mean, this is allowed thinking. It's time to take a call on whether we can pick up items which the center needs to support, provided there is an assurance that the basic things that are required to get to that place are available from the state side. At present, it's a structure where the states are reflecting their gaps and necessities, which is being filled up by the center through the PIP process. It is not necessarily the input-based program that Government of India has designed, which they have to follow. It is the state's felt need that is being reflected through the PIP. And I feel this is a good process where each one is getting what the particular state feels is actually essential for their healthcare system.
So let's hear from the states on this topic. I'll invite Mrs. Arti Ahuja, who's Secretary Health from Orissa, and ask her to talk to us a little bit about maybe two questions. In what does it feel like from your side? What is the experience so far? What do you anticipate will happen going forward? And maybe more specifically, is that PIP process something that reflects how you would like to interface with the center?
Sure, thank you. Glad to be here, especially with so many junior and senior colleagues and friends here. Just very briefly about Orissa, if I may. The social indicators, IMR, MMR, have been decreasing, but at a slow pace. We are still considered a backward state. Coming to health financing, if we see overall as a percentage of the total budget, health sector gets about 4 to 5% over the last 3 or 4 years. But as a percentage of the GSDP, it is hovering around 1%. In terms of the plan and non-plan expenditure, it's more or less the same. Now, when you're talking of health and health systems, it's always a yes, but kind of a situation. We have all those things happening, yet there's a declining resource pool. We just talked of the change state share. Of course, the money has been devolved to the states, but in case of Orissa, what I understand from the finance department is, although the state share should have gone up, but because of the fiscal prudence followed by Orissa, in actual terms, the money has not come to the state. So the state actually has been penalized by being fiscally conservative and fiscally prudent. There's a smaller share now because of this devolution. So much so that even the state's own finances have gone down because of the mining revenue coming down. So there's less money in the kitty, and the state even had to do market borrowing. So we are talking of a very shrinking resource pool at the moment. From the Government of India side also, last year has been tricky. We've had the 60-40 information just came very recently. So the states have been unable to plan accordingly. We were going ahead with the 25 thing. The devolutions in kind, for example, the long-lasting bed nets and the HIV testing kits, etc., the supply has been erratic. So both in terms of funds and in terms of goods in kind, this year has been an year of extreme resource crunch as far as the states are concerned. Now, where is it that the pinch is being felt? First of all, as is true for most other states, I guess, there are huge vacancies. There are doctors not in place. We have, and incidentally, let me tell you that we have a total budget of about 4,000 crores, of which Government of India budget is about 1,000. So roughly 75% is in any case spent by the state government. But over a period of time, the way systems have evolved, the way it has been set up, we have this situation of extreme, as I told you, financial crunch currently, and human resource crunch. And this has happened, again, because of the fiscal prudence being followed, because of other reasons as well. And again, true for Odisha, I don't know how far it's true for other states, but when we are talking of the public and the private provisioning, the majority of the population is still very much dependent on the public sector. We have very little by way of good private sector. When we are talking of private sector, in fact, it's the government doctors doing private practice in the rural areas. So that division is there, and the public sector still caters to a majority of the population, especially in the rural areas in Odisha. So while we have this crunch, on the other side, we have the rising expectations, rising and increasing commitments. In our essential drug list, we have 570 items which we need to supply to the facilities. We have a drug budget of 200 crores. It's been growing exponentially year on year. And once these kind of commitments are made, it's very difficult to roll back on them, and you have to commit that much amount of funds to those. Plus, there are the ambulance service, the caseload is going up at different levels of institutions. The bed strength over a period of time has not officially been increased. So you find across the country, I suppose, people lying on the floors, because officially we have not recognized that actually the bed strength in these institutions has to be scaled up. Accordingly, the diet charges, the personnel, et cetera, have to go up. So we are in that stage presently. Plus, you have the media that highlights everything, leading to the pressure. Now, I have 3 things that I'm going to talk about. Number 1, we need to tap other resources for reduced out-of-pocket expenditure. And what are those sources? We have the number 1, insurance. We have the RSPY. In our state, we also have something called the Krishak Kalyan Yojana, which is an insurance scheme only for the farmers, which is implemented by the Agriculture Department. Together, they cover about 69 lakh families out of a total about 100 lakh families in the state, so which is a pretty impressive coverage. Plus, there are the other central government schemes like the Anganwadi workers insurance and the handloom and sericulture insurance, etc. We also have a top-up for the episodic illnesses, for the high-value illnesses, which is paid from the Chief Minister Relief Fund. Then we're also going in for more PPP. We are looking at low-cost hospitals. In all the district headquarter hospitals, we've done an analysis where 100-bedded, where 200-bedded, etc. We are going in for PPP for medical colleges. We are going in for PPP for specialty healthcare facilities like cardiac care in different places. Looking at tapping other funding sources like Tata Trust, GFTM, etc., to partner with us in things like malaria, etc. We also have, but I would also like to point out that one major source that we often tend to, probably we need to factor in as far as other resources is concerned, is also other schemes, like the whole NFSA is going to raise real incomes across board, and hopefully that is going to impact on the health expenditures as well. So we need to look at that. We need to look at the pension schemes, and in the case of Odisha, we have a conditional cash transfer scheme called Mamta, for the 1,000-day, covering the 1,000-day period, where conditional transfers are made electronically to women when they follow certain health behaviors related to their pregnancy and further for the child. So this was about tapping other resources. Now, the second point that we need to look at is efficiency in expenditure. Very rightly said that there is limited capacity for spending. It varies from state to state, but definitely you pump in too many resources at one time, there is a limitation to that. We can set up systems. There was an example given, for example, the corporations that do procurement, drug procurement. Tamil Nadu started that, Odisha now has that, and we rolled out a free drug dispensing scheme right up to the CHC level called Niramaya. So that is, again, what happens when you do these kind of things is when you have centralized procurements, e-tendering, etc., again, in real terms, the budget goes up. So although it's 200 crores, but compared to the earlier, one is able to procure a much larger corpus of medicines. Prescription audits, the whole the NHM construct of flexipool, untied funds given at various levels also increase I feel they increase the efficiency in expenditure. People, decision makers at that level are not constrained by too much of regulation, and they're able to spend where the money is best spent. I'd like to tell you something about what we have done very briefly about optimizing our resources. We have recently done an evaluation vulnerability mapping of various institutions, and now a specialist working in a V4, the most vulnerable institution, can get up to 1 lakh per month extra. Non-specialists can get up to 80,000 a month extra just for working there, and we find a very positive response to that. A lot of people are now opting to go work in the remote areas. Like you mentioned about the local self-government, we have created a corpus fund, or are going to create a corpus fund at the district level, where the collectors would have the autonomy to do whatever it takes. Even if it means providing transport to the doctor or paying his rent or whatever it takes, or even paying over and above the government salary or paying a contractual doctor 5 lakh rupees a month, whatever it takes, we are going to give them this corpus and they can spend on that. To enforce accountability in the private hospitals, amending the Clinical Establishment Act, standard treatment protocols, help desks, helplines, community scorecards, citizens' charters, publications of entitlements, referral protocols, etc. Lastly, today I was reading in the morning newspaper that Bob Dylan has been inspiring many medical scientists. I don't know if there are any answers blowing in the wind in this case, but I have a few points that I'd like to make before I end. Number one, let's recall that curve that we saw in the OECD presentation and where India is. Now, my experience in the nutrition sector shows that if you push one agenda, if you push one message, for example, the GNR says, invest 1, you get 16 in return. Just look at that slide. Look at the uphill thing that happens with a slight increase in resources. I think all of us who feel strongly need to commit and need to push for that kind of a singular message with the policymakers. And all of us, it's like preaching to the converted, but I think people who are not in this room need to also learn about the magic of that increased expenditure. Secondly, increased devolution from the center is mandatory because there's also a political economy involved. The states many times can leverage, can negotiate with their own governments by saying, oh, this is what the central government wants, I'm helpless, I have to do this way and not that way. So it's important that we have those kind of central devolutions. Third, we see expenditure on people in the health sector as a revenue expenditure, but for healthcare, health service delivery can only be done by the people. They need to be treated as capital expenditure, and we need to spend more on those resources. Last, today, health has become a marketable commodity. I think even 15 years back, when Amartya Sen wrote about it, it was a marketable commodity. It is time that we recognize that there is no substitute for public sector, especially in these so-called backward states like Odisha, and we need to have more and more devolution of funds there. We need to really jack up the expenditure and have more efficiency, more accountability there. Thank you.
Thank you. Thanks for your presentation. And thanks for Mr. Sumitra Ghosh for joining us last minute. So I'm sure you don't have a presentation. but maybe you can reflect a bit more spontaneously about some of the things we have talked about from the state level, both from the experience so far, what it has felt like, have you been able to get more resources now that the money is going to the state, and if not, why not? If so, why, how so? And also, what is the expectation of the center going forward, in the sense of what is the role you would like them to continue to play vis-a-vis you? Funder, obviously, but besides that, what is the role that you expect them to continue to play as a steward, as a supporter of your work in the state?
Good afternoon, everyone. It's a privilege to be able to present the state's point of view, my state's point of view, before a very distinguished international audience. I come from West Bengal, and to give you just a very brief health profile of our state. It's a 90 million plus population state, one of the largest states in terms of population, packed very closely into a very small area. So we are the densest populated state in the country. The health infrastructure that we do have right now is 13 medical colleges and about 100 more hospitals. The medical colleges are at the tertiary level, 100 hospitals at the secondary level in the districts and the sub-districts, and about 1,300 health facilities in the primary healthcare system. Besides that, more than 10,000 sub-centers working at the grassroots level. And with the health facilities, more than 1 lakh employees. We are one of the largest employers in the state, working to improve the preventive and the curative health aspects of our people. Health, as we all know, is a state subject from the legislative point of view. Having said that, we value the partnership that we have with the union government in a federal structure. And the partnership is not merely in terms of funding. We will come to that later, although that is the focus of this session. More importantly for us, the partnership is in terms of policy making and in terms of developing systems. Funds, of course, as everyone has been pointing out, but this was the expected and announced scheme of things anyway, that the center will gradually withdraw its fund support as states come in more and more. So far we have been having a 75-25 ratio in the fund sharing in the National Health Mission structure at least. This year, in the middle of the financial year, we hear that, as I said, this was expected. It was not an unpleasant surprise. We were preparing for it. The center share has shrunk to 60%, and the states are contributing 40% to the total NHM kitty. The basic understanding here was that with the center hand-holding us for such a long time and giving us so much of fund support, the states would be able to, in the course of time, develop their own capacities for spending. And that is where we are at, and we are all working towards it. That was the spirit behind the thinking. In West Bengal, we are in the spirit of the entire, the national health policy. We are moving towards ensuring universal health coverage. Here, our opportunity and our responsibility and what has made things easy for us to assure a universal health coverage to our people is that more than 80% of the population depends on the state institutions, on the state health facilities. So this is a huge responsibility for the government, but it's also an opportunity. And it is easier, I think, to push through universal health coverage when we have so many people, coming to us. So it's easier for us to, put systems in place to take care of them. Universal health coverage in India, of course, was given a fillip by the National Health Mission with schemes like the JSSK coming in, assuring pregnant women and small and infants of zero out-of-pocket expenditure for all their health needs, and it was followed up by another huge program, the Rashtriya Bal Swasth Karyakram. Keeping in line with that spirit, we in our state have also assured a free drug policy. The policy is already in place for the last 2-3 years. That was part of the Health Mission mandate, and we accepted it gratefully. We are not only looking at free drugs, we are also trying to ensure free diagnostics of very high quality to our people. And our experience has been that this has not really cost us too much. It is not a prohibitive cost. It is nothing that the government cannot afford, and it is nothing that the state government can't afford, leave alone the central government. Our health budget in our state in West Bengal, it is 6,000 crores annually, and of that 450 crores is on drugs. Of the 6,000 crores, about 800 to 900 crores is a central government share. That's part of the NHM devolution that they give us. A large part of our state budget, of course, goes into salaries. As I said, that we are one of the biggest employers, but people are important in the system. So we can't really cut down on costs there. Where has the NHM framework helped us? Our experience has been that fund has not been a constraint so far, really. That's not what we have felt in the state. As the ASMD keeps dinning into us, what is more important is that while we do put in, more money for health, it is much more important to ensure that there is more health for money. There has to be smarter spending. The spending has to be prioritized, it has to be optimized, and it has to be very, very focused. We can't spread it all across and not achieve optimum results. And this is where the NHM structure has helped us. It has brought in much sharper thinking. It has helped us in focused planning. It has helped us to identify which are the infrastructure areas we need to upgrade. For example, the mandate here is to improve our maternity and child and the pediatric wings. So that is what we have been doing, because that is that's where the maximum number of patients come in. Most of the pregnant women are delivering in institutions. So the labor rooms need to be good. The OTs need to be good so that there is no sepsis there. The maternity wards need to be good. So that is where we have channeled our spending. We know our requirements in manpower. We know the kind of people to hire. We know we are very sure about the profile of the people when we are recruiting them. We are very aware of their training needs. So the training is much more focused. Training is a challenge because where there is manpower shortage, that's a universal shortage. We can't really afford to withdraw the workers from their workplace for too long a time and give them useless trainings. So the training has to be very, very specific to the area of work. And we are going in more for on-site training so that daily routine work is not disrupted. It has helped us, NHM has helped us in developing monitoring systems, in keeping a watch on how the people, on measuring their outputs. We are incentivizing them as the other states also are. We are linking payments to performance, not only for our community health workers like the ASHAs, but also to our doctors and nurses. It has taught us the importance of targeted publicity. The IEC, so to say, the information, education, and communication is now much more structured. And it's in keeping with the needs of the people. We know how to address our various target groups. We know the language we need to speak into the mothers. When the mothers are concerned, we know the language we need to speak in where adolescents are concerned. NHM has helped us to understand and assess the emerging health needs of the people. For example, the three brightest examples are factoring in adolescents into the entire health delivery system. This was a group that we had not looked at to our own peril for till 2 or 3 years previously. We have now forayed into the urban health sphere also. That was another emerging need. So it's time that we, we took cognition of that in very good time. The non-communicable diseases are a new child on the this is something new on the anvil. So programs are being developed. The National Health Mission has been developing programs to assess the immediate requirements of the people. So that is where the value of the health mission is. It has also helped us to understand the importance of convergence. Health is an area where we simply cannot go alone. And this has been drilled into us, and we now realize it is so important to take on board so many of our other departments, the education departments, the women and child development departments, the social welfare department, the rural development department, the municipal affairs who are looking after the urban space, the PHE, which is supplying clean water. So all of them are now working together, and this helps us to optimize our resources, to avoid, to cut out on duplication of efforts. So that is where the value of NHM lies, and through NHM, of course, the central government lies in for us, not so much for funds. And fund commitment is something that West Bengal has stood by very, very strongly. We have increased our health budget in a very conscious manner, by at least 10% every year, and we intend to do so. And contributing our share of 40% has not been a problem at all. It was, 25% had never been a problem, 40% won't be either. So what we feel more importantly is that the challenge is not in channelizing more funds. We have so many other resources which we can tap. We have the RSBY, we have other health insurance schemes run by other departments for the marginal workforce. But the challenge is really to ensure that all the good intentions about free drugs and free diagnostics are really reaching the last point. We want to see that the patient in the ward, the patients who are coming to our hospitals are actually getting the drugs that they need for their treatment entirely for free. For us in the state, that has been the challenge and not the funds. Thank you.
Thank you so much. A bit of a different story we heard from Orissa in terms of both how you talk about the funding crunch at the state level and the relationship with the NHM at the center. But I want to make this a bit more fun, so I want to invite people from the audience. I'm sure there's lots of questions.
I'm K.C. Shah. I work in Bihar. I would like to bring the Bihar perspective. I would like to make an appeal to C.K. Mishra. Mr. Mishra, you have to support, if at all anything, that is the maternal and child health. The structure, which has been carefully built over the years by the good work done by the stalwarts in the health ministry, Sujata Rao, Desi Raju, you and others, now it is getting demolished. And it is like abandoning the child when there's nobody to take care. Now, my observations are based on visit to 30 districts, 330 PHCs in the last few months. Now, why this appeal? In this year, the State Health Society, which has the capacity to spend 2,000 crores, the expenditure will not be more than 500 crores. As a result, ASHAs are not getting paid. Incentive for deliveries, 1,400 not getting paid on time, and so many other defaults. You may blame the people in the remote areas. They don't know whom to blame, whether Mr. Govind Rao, or the state government, whether in the union government. They are wondering that these facilities were available, but now I don't know what is going to happen. So my appeal will be like the health minister of Turkey. You have to sleep in the health ministry for some time and plead for funds for states like Bihar. Otherwise, the good work which has been done over the years, it is going to be demolished. And I don't know whether the Finance Commission, they had heard the cries of the people in the remote villages, the facilities they were gone, when they made their recommendation. Thank you.
Thanks. We're going to take few quick questions, please, and say who you are.
Two very quick questions. I'm Yamini. I work with UN Women. My first question is to the government representative from Orissa. When you said that despite this untied funds being devolved to the states, Orissa didn't really see any increase in the pot of money you have because of fiscal prudence. Was that because of the Fiscal Responsibility and Budget Management Act? And if yes, then would you agree that the FRBM Act has been responsible for then constricting important expenditures being incurred at the state level? And my second question, can I just finish? I heard that in the panel that again and again that will this untied pot of money that has now reached the states will help be prioritized. And I work on gender and we're all asking the same questions. Will gender issues get prioritized? What will this pot of money be finally used for? And I do understand that we'll get a clear picture only after about a year or so, but given that it's a political, budgets are political, in your understanding, in your reading of the scenario, where do you think this untied pot of money will actually or likely be used?
About your first, let me take your second thing first. It's, as you said, it's not clear yet how the priorities would be. Again, as I mentioned the word political economy, how things play out is very different because anything you do in health has a long gestation period, and people at the helm of affairs would definitely like to see bang for their buck very quickly. So how they prioritize, it's very difficult to predict. But definitely, short of sleeping in the finance secretary's room, we are trying to do whatever it takes to get more money. And let me tell you, like West Bengal in Orissa, it's not really a problem. Recently, we had 100 crores additional. In supplementary, we got 300 crores additional. So money is not really a problem. What is important, what I was saying about central devolutions is it provides a leverage. It provides a professional leverage, a managerial leverage, and a financial leverage. It fills the gaps. So that's why it's important. It's not just the quantum. Coming to the fiscal responsibility, yes, the Act has been responsible, and Orissa has turned out to be fiscally conservative. There has been a cap on new recruitments. Fiscally, it's doing well. But probably it's time now for us to take the big leap. And as I already mentioned, there has been market borrowing this year to fund some of the schemes. So probably state will have to look at generation of revenue from other sources in the future.
I had a question from Mr. Girindre, which keeps coming back, and I keep forgetting to ask him. But then I think everyone will benefit, so I'm asking you. That is that in the devolution package, 42% is what you have given to the states, is the same ratio as the previous finance commission. So 60, what is left then? 42, what is it? Yeah, 50. And that is still with the central government. Wasn't that the same ratio as the previous commissions? So why should the central government today be saying that our flexibility or our resource base has been reduced and now go to the states? The proportion of what money was being devolved to the states is the same. It's only that inside that devolution, you have given more untied money than tied money. I'm a bit confused on this conceptually. Please kindly.
Thank you. I think that needs clarification. You know, there has been an increase in the tax devolution by the Finance Commission, you know, from the divisible pool. Earlier it was 32%, now it is 42%. But that 42% includes the planned transfers that were given earlier under the Gadgil formula. And also, you know, the Finance Commission itself abstained from giving all sorts of discretionary grants. So the comparison generally is between 39 and 42. Basically, that's one. That still left a significant proportion of the fiscal space to the union government. But then the union government didn't want to give additional money, and therefore in their budget, they cut down on the allocation to centrally sponsored schemes from somewhere about 2.9 lakh crores or 290 billion rupees to 2 lakh crores.
No, so the question is central government still
has
a lot of money.
Absolutely.
And Jollyville can reprioritize.
In fact, if one looks at it as a part of the
So, Mishra,
divisible...
you don't accept what they tell you.
No, as a part of the divisible pool, overall, you know, earlier it was 61% had gone to the states. now it is going to 63% going to the states, just a marginal amount that is going to the states. I mean, that's the way we had calculated. Now, I mean, Mr. does have a problem. I'm not saying that he doesn't have a problem. And the problem... No, listen. No. I mean, the problem is that when they cut down on the centrally sponsored schemes, allocation, the allocation, they did, continue to retain the same number of schemes. As I said, almost 50 schemes they retained. So the allocation to health was increased only very marginally in terms of absolute terms. That's basically the thing. Because because that prioritization on the centrally sponsored schemes, I do not know to what extent the health ministry was involved in that. Possibly the Ministry of Finance has done that. So they have a number of schemes. You see, they bring up new schemes. Now you have Swachh Bharat and you have Namami Gange and you have various other schemes that are coming up. So, additional amount that comes in to health sector, I mean, it has, at least in the budget, it has not been very significant.
A comment and a question, both in a sense addressed to Mr. Mishra. Well, not so much sort of to Mr. Mishra as to the central ministry, the union ministry. The secretary said in the morning that, we're doing quite well. We've achieved the MDGs on health. It's not entirely clear whether that is, in fact, the case, because the data tells us that Mdg goal IMR was 27 by 2015. We actually achieved 40. So we are very far away from the IMR goal. So first, this is a mindset issue that we are pretty much doing okay. The second is about the financing. We keep hearing money is not the issue, but at the same time we get questions about or issues around, well, we know rather that the data is telling us that increase the money, the results come. Isn't it possible, sir, that money is not getting utilized or there are utilization issues because we just don't have the human resources or the drug procurement systems in place? That's why we are not procuring. So if, for instance, slowly you were to create more human resources who can then absorb more funds, and at the same time insist with states they create a Tamil Nadu type drug procurement system, which the Tamil Nadu government did 25 years ago, but many governments of this, in the states have not succeeded in doing, then there's a possibility that you will be able to increase allocations and the absorption will gradually increase automatically. Gradually, as Aarti rightly correctly pointed out.
Ashok Babu, Mission Director, National Health Mission, Assam. Sir, the discussion says that democratization of funding, devolution, etc. But I feel, sir, this will not serve the purpose at all. I worked in the district, now I am in the state health headquarters. So few people, they will not raise voice, they don't have bargaining power in the democratic system, and they don't demand also, they don't have health-seeking behavior. They are satisfied with whatever MMR they are having, they keep on dying. And they don't have political power. Just like Philippines example, LGUs, they are not concerned about spending their own money on health. I can give multiple examples, sir. Those minorities who can get the fund in democracy, those minorities who remain silent and keep suffering. What is required for this, sir, is we are not simultaneously evolving certain principles. They are not instructions, guidelines, how after development these things should reach those who only will improve our IMR, MMR. Otherwise they keep on, this distance keep on defeating them. And what is required, sir? Some guidelines, principle, say some statistics. I don't know, sir, what is happening to my MMR. I keep working on 3 years back MMR, which is a Western indicator. And I don't know what is happening in my district, leave alone on pocket. I get MMR for 5 districts together. Next 3 years, sir, I will be searching in the blindness. We are devolving, we are empowering local units, but we are not guiding them, sir. And these people are also take decisions on certain things where they more clamor, they get more funds. Somehow we have to plan for this also, sir. Thank you.
2-3 issues, so quickly reacting to that. First to Mr. Saha's point about MCH. Yes, sir, whatever it takes to go to the finance ministry, we'll do. And perhaps we've already seen the spot where we can sleep. But the issue is, as far as Bihar is concerned, it's really disturbing that the delivery mechanisms at the field level for the last year and a half or two have not really been working. In fact, the footfalls have been going down, the institutional deliveries have been going down, drugs, etc. One of the reasons. But it is not that the RCH component of funding has gone down. In fact, the RCH component of funding has been increasing every year. Unfortunately, that allocated fund has not been utilized. And I fully agree with you that it's time that we need to think of a system where we can from here also make a push which helps things in the district, because that is ultimately where the success or the failure lies. Mdg goals are often talked about because that is the global accepted indicator to development of health. There are several others, but we keep talking about Mdg goals. The Mdg goal that is prescribed and which we have to achieve is related to MMR and U5MR, which is the under 5 mortality. And when the Secretary spoke about being there almost, it was with respect for reaching 140 as far as MMR is concerned and 42 as far as the under 5 mortality is concerned. Right now we are 49 as far as the under 5 mortality is concerned, 167 as far as the MMR is concerned. But if you take the rate of decline, these are 2013 data. So, and 2013 data really means that the data would have been collected from somewhere towards the end of 2012. So we don't have any data for 2013, 14, and 15. But the projection that you normally do, and this is a standard thing that every international organization also does, the projection that you do based on the rate of decline shows that we are either there or we'll miss it by a point or so. But that is not, according to me, the center of what we are looking at. Whether it is 140 or 141, it does not really matter as long as we know that we are losing 44,000 women every year. I mean, that is the concern. You spoke about HR strengthening and system strengthening. I mean, I fully agree, that's the key. And if you look at the National Health Mission spending pattern over the years, close to 60% is being spent on HR itself. Because the initial idea itself was give them more HR so that they increase, I mean, they are in a better position to increase their capacities to absorb. It has not happened uniformly, but in some of the states where they have been able to do it, the absorption capacity has increased. And just to share, the absorption capacity year-on-year basis has been improving across all states. I mean, some years, some state may have a problem and the other state inside, but absorption capacity has been improving. Still, there's a huge gap. And unless we emphasize this HR and emphasize system strengthening, that capacity is not going to come about. And I am a strong believer that that is one of the main focus areas of NHM, and that should be it. To Ashok's point, yes, there are issues. Health-seeking behavior is also related to availability of services. If you look at health-seeking behavior in Kerala, it is not as if people there were born with this, but they have seen facilities where they can, go for healthcare. So one of the things that we really need to do is create that infrastructure and the structure which assures the person that there is a healthcare system available and there is a quality healthcare system available. But yes, you have a problem in terms of the knowledge itself being not there at a disaggregated level, maybe in a subdivision or so. But in today's system, data is critical. It may not be nationally accepted, evaluated data, but if you have a system where every facility is reporting, then you would perhaps know the magnitude of the problem. But yes, I agree with you, even with knowledge, maybe that does not come into focus because there are other competing priorities, even within the health sector. Even within, I fully agree with you on that.
Number one is the whole issue of utilization rate. You know, I mean, all the time we talk about absorption. Yeah, there is also an issue of, you know, ability to pay the matching requirements. You know, that's precisely the reason why I said, you see, you need to really, you know, work on that. Because, I mean, you have a uniform matching requirement for everybody. And you are not able to offset the general fiscal disabilities of the states. And when you are not fully offsetting their general fiscal disability, their ability to contribute to several schemes, you have, you know, as I said, 147 schemes. Their ability to contribute, matching contributions are not the same. So because of that, you know, there may be a possibility that the absorption, you know, they are not able to absorb. So we do need to have to find, you know, that's one. We do have to find a solution to this. And if you don't do it, and then if you redistribute this particular amount of money to the remaining states, you know, you're fine. I mean, you have utilized. Obviously, the Minister of Finance, you know, Health doesn't want to return the money to the Minister of Finance. That's understandable. But if you, redistribute to this thing, you are basically giving more to the same set of people and not, you know, not to the needy. In other words, the original allocation plan gets completely, you know, this thing. That's one of the major problems. It may be 10%, it may be 20%. But then, and that's the reason why I said possibly we'll have to look for a multi-year budgeting system where, you know, you need to work on that. That's one of the things. Now, on the, you know, I mean, there are, you know, see, health, you know, sort of status differences between the states can, you know, arise for a variety of reasons. I mean, we keep talking about Kerala or even Tamil Nadu. But in Kerala, you should know the history. And in the history, much of the health infrastructure was put by the Travancore Cochin Maharajas in the earlier, and later the missionaries. And when the new government came in, I mean, the independence came in, the government started putting more money because there was already a lot of infrastructure and they had to maintain that. So even with that, I mean, the out-of-pocket spending in Kerala is not any less. I mean, in fact, that, you know, with all that. Now, what I'm trying to say is that whatever be the cause, the point is that advantage doesn't exist for many other things. We didn't have the rulers like Travancore, you know, Cochin Maharajas, who put in a lot of, you know, made a lot of investment in both education and healthcare there.
Thank you so much. So we'll bring this to a close. I won't even attempt to summarize this conversation. It seems to me that my hope at least is that, you know, when you think about healthcare systems, kind of basic functions of stewardship, financing, and delivery. And the government, I think, with this new devolution at the center, will need to think about what given the financing role is being somewhat constrained in absolute terms, it is the same, but it's not going in the trend that we have seen in the past, and therefore its role versus delivery may also be constrained. What is this kind of stewardship role it needs to play more strongly vis-a-vis the states to enable that devolution to work well? And what is investments in data systems, investment in how do you accompany the states from the policy lens and so on that needs to be done? So with this, I'd like to thank all the panelists for a lively discussion.